Yeah, we started our experience last year in November and focused in our cases on the aortic, aortoiliac area. We have the device has been previously described, and of course it's very interesting for the surgeon to be well seated and comfortably seated during the procedure. But we have two main advantages in this robot. It is the capabilities of an intraluminal navigation and the stability of the device. It's what we used in this area of aortic procedures. We have done now more than 28 procedures, but we work on arteries and also on veins. We have done some treatment of aneurysm for cannulation of the contralateral limb. We have done mainly cases in the treatment of lesion, stenotic lesion in the aortobiliac area, and also embolization is what I want to show today. About the device, we all know that sometimes it's not so easy to recanalize a lesion, highly fibrotic or calcified lesion, and we strongly believe that the robot can help us with the stability of the leader using the advent of the guide and the leader, and to pass through the lumen. Sometimes we use also the sheath. We pass with the sheath, but also adding a small band to the leader to find a hole to go subintimately and to re-enter in the true lumen. I'll show you 4 cases, 2 for recanalization. The first case was a case we've done at the beginning of our experience. It was a young man suffering disabling claudication with no particular past history. He had this occlusion of the right external artery. And we propose a procedure, the angio, before you have some lesion on the common and the external left iliac artery. We went to the stump, we had a little stump, and we passed through the occlusion with the guide with the leader. We re-entered directly in the common femoral artery. We have done 3 angioplasties on the iliac. The sheath is at the origin of the external iliac. The control demonstrated some dissections. We treated by the placement of the self-expandable stent. In this case, it was a Tigris stent. With the final control. The postoperative course was uneventful, and the patient is well. The second case was interesting because it was a 62-year-old man, and we failed in 2 attempts to recanalize a very short and heavily calcified common iliac lesion. We failed from the groin, and we tried again from the groin. We failed because we were subintimal, and we never re-entered the aorta. And we attempt from the brachial access. We had never enough support to pass the occlusion. We decided to. It's the very short lesion we can see, and we decided it's the pre-angio procedure at the time of the angio at the time of the procedure. You see this short lesion with some aspect of past dissection. We decided to come from the right side and to use the stability of the sheath to pass through the occlusion. And it's exactly what we have done. And we got, in this case, enough support to bend the sheath and to pass through the occlusion with the leader and to go further with the sheath in the occlusion. We had to remodel all the external iliac we dissected before. With 2 stents. And we're able to do an angioplasty at the origin of the common iliac, and you deployed with accuracy a stent at the origin of the iliac.
The stents you're placing through the robot
Yeah. Patient was well too. Two cases of embolization that could probably show some interest of the robotic aspect. Device, it was an old man with multiple comorbidities that we treated 3 years before with a custom-made EVAR. You see the case with the thrombus in this part, but he developed larger than 3 centimeter iliac aneurysm. But what was interesting, we had a short neck here, and we decided to treat it only with embolization, and we cannulated first from the groin, from the ipsilateral groin, and went very distally, and were able to deliver through the leader some coils. We added a short Hamplatzer plug. We still have some distal perfusion. We are very stable, and we had still a perfusion, distal perfusion, and we use microcats in order to pass Boston coils and to fill the sac. You see we are very stable in the aneurysm. We had no more distal perfusion. We had some clots, and we placed the sheets very at the ostium of the iliac, and you see the stability of the device allowing to deploy the plug just at the origin and getting a perfect occlusion of the aneurysm. And the patient is well, and we had a control 6 months later. Last case was a patient we had been previously treated for AAA, and who had this aneurysm of the left internal iliac artery. We had no neck, and we decided to treat it conventionally with embolization and a covered stent. But in this case, you see the aspect of some tortuosities. The robot for us helped us to cannulate easily to find the aneurysm. And you see here, we are able to deploy some cords in the lower part and in the upper part to selectively cannulate some arteries, distal arteries in the stump of in the distal part of the internal iliac aneurysm. We deployed this cord, and thereafter we use the robot to go in the left limb of the graft and deployed. We have to retrieve the robot because we deployed via band and required a larger sheath. It's a nice control. The patient was well, and the aneurysm completely excluded. Our preliminary experience confirms that the robot may help for to get a precise endovascular navigation, and also we have a high level of stability of the device when working. For CTO, we use it as a useful tool to cross some occlusion, and we find that the stability allows to do some crossover without any stamps. That we are starting a series of patients in this special indication. Concerning embolization, it's the capabilities to move the leader in the aneurysm can allow us to easily do some different kind of embolization, distal embolization, and the stability can also do some embolization using plugs at the ostium of the artery. Thank you very much.